Hey guys, this is Vicki. I just want to take a little bit of time to go through quality in regards to nursing. As we all know, quality is essential in order to be able to provide effective care for the patient and family in regards to evidence-based practice. So one area that I want to take a look at is what is quality in healthcare. We know that the Institute of Medicine, often abbreviated as IOM, established recommendations for the new standard of nursing. And these standards included the 6 bullets: patient-centered care, teamwork and collaboration, evidence-based practice, quality improvement, safety, and informatics. So I want to take a few minutes and look at each of these. So first we'll start with patient-centered care. We know that patient-centered care incorporates patients' preferences, values, and expressed needs. We also know that the nurse really should value seeing healthcare through the patient's eyes. We know that patients and families participating in decision-making and collaborating with the care that is being prescribed is the most effective in order to sustain or maintain a healthy individual or to improve the health. If you think about a patient situation that you may have experienced, we'll take a COPD who smokes. The nurse and the provider can, create a great plan for the patient to stop smoking, maybe put them on Chantix, maybe giving them some nicotine gum. And they can prescribe and we can teach and we can do all the nursing interventions supporting COPD and smoking cessation. However, if the patient and or family are not on board with this plan of care, we've done absolutely nothing for the patient. We need to ensure that when we're creating our plans and we're discussing different interventions, that we are integrating the family's thoughts, the family and the patient's thoughts, beliefs, and where they really foresee themselves going with their health care needs. If we don't do that, then we may or may not be missing different interventions that we also need to consider or incorporate into that patient's plan of care. The other area is respecting diversity. As nurses, we must respect diversity of individuals, groups, and their families. We must understand how diverse cultural, ethnic, and social backgrounds function as a source of their patients' values, and it's from these values that they are driven to make different medical decisions. We have to communicate these values to the healthcare team so that when the healthcare team is creating the medical plan, that it does get incorporated so that the probability of patient success does improve. And we must understand how patient and family values can differ from that of not only your own, but also of the healthcare teams. And again, it's all about making sure that we keep the patient at the center of the care and we create their plan not only according to evidence-based practice, but also to their preferences, their beliefs, and if they have any diversity values that we need to encapsulate and incorporate into that plan. The next big component is teamwork and collaboration. We know that 66% of healthcare errors are related to poor working relationships between providers and nurses, nurses and nurses, nurses and pharmacists, and also the communication tends to be poor or decreased when an error does occur. We also know that teams with effective communication demonstrate better patient outcomes. So the essential components to patient safety is team training and enhanced communication. We need to be, as a future nurse, it is important to always make sure that whatever you're communicating is clear, concise, and if you have questions, make sure that you're following up on it. When you're delegating, making sure that you're delegating clearly, that the person understands what you need done, the follow-up is completed, that they come back and check in with you to ensure that the delegated task is completed and completed correctly. So it's not only communication, it's following up. When we think about a team approach, we have a standardized team approach that really should include sharing concerns, clarifying decisions about care, and ensuring adequate accurate and adequate information is exchanged. So team members, just as the slide says, should share concerns, definitely clarify decisions, ensure adequate information is exchanged. If you are not hearing what you need to hear, you need to ask questions and clarify. Sometimes if this is with a family member, it may be even paraphrasing what they just said. Let me see if I understood you correctly, and then paraphrase what they said. Because if you're not understanding what your team is saying or what the patient is saying, you're not able to effectively create or ensure a safe environment. I also want you to make sure that you use situational monitoring. So when you become a new nurse, you may not fully understand the situation in its complexity or the holistic situation. So I encourage you to use a check and balance system. And this is what I think of as a check and balance system, is kind of watching out for each other's backs. Meaning if I have a question, I've created a mutual trust with my fellow colleagues, my peers, maybe my mentor nurse who's working with me, and I go and I ask her about the situation and the environment in which the patient is presenting him or herself, and I talk to them about what I'm doing, why I'm doing it, and this is that check and balance, especially as a new nurse, or if you're a seasoned nurse but in a new patient environment. It's important to use the situational monitoring to make sure that safety and quality are always put at the highest level possible. And then we also use situational awareness, which is about sharing, like I said, it's kind of the same, but it's sharing perceptions to avoid confusion. So making sure everyone is on the same page and that we're really all working towards the same goal. So we talked about communication already, or we soon will be, but team communication is essential in order to provide safety for our patients, safety for our team, to improve the quality of care that's being provided to our patients. So structured communication ensures accurate information is exchanged, shared decision making is being completed, and we're also reducing the potential for errors. So using SBAR is essential when providing report, especially with a provider. When we think about call-outs, I often think about code situations or maybe traumas, that when there is a heated moment and there is critical information, that we're kind of shouting, making sure that everybody is understanding, calling out, saying it out loud, what's really going on in with the patient. Maybe the hemoglobin's really low, so we do a call out of the hemoglobin of 4.4 or whatever. We use check back, obviously using mutual support. Handoff report is really growing, which is a great thing to see. Handoff reporting, if you remember, is that handoff communication that's done at the end of the shifts. Most facilities have now moved that to bedside reporting, which is excellent because the patient then is also involved in the report and they understand what needs to be done or what did get completed, so that they can be an active member of your team, the patient. But it also ensures that nothing is forgotten and all critical things are assessed, such as the IV rate, maybe chest tubes, maybe a pacemaker, maybe an incision. Things like that are all being addressed, and you have two eyes or two sets of eyes looking at the patient and knowing that when nurse A leaves, I know what this patient looked like, and this was what the patient looked like all day. There is some critical language, key phrases that can be used by all team members to clarify information. The CUS stands for I need some clarification, I'm uncertain, or I have a safety concern. And then the 3 C's stands for I'm curious, I'm concerned, or I'm still uncomfortable, so let's consult a third party. So these really are your crucial conversations. When we think about evidence-based practice now, we're going to shift this a little bit. We know that evidence-based practice ensures safe, high-quality nursing practice. We know that nurses have to juggle constant changes in healthcare with patient preferences, and evidence-based practice integrates integrates best current evidence with clinical expertise to deliver optimal health care. We also know that research helps identify valid reasons for modifying evidence-based practice. So many nurses, if they're old school, maybe want to do it status quo, but please know that evidence-based practice is a constantly evolving and it's really based on scientific knowledge, research, patient outcomes, and what is in the patient's best interest to ensure that their medical needs are being met in the best possible way forward to improve the patient's outcomes. Most oftentimes, facilities will have either a clinical nurse specialist, or they may have research teams who are constantly reviewing evidence-based practice, journal articles and things like that to see what is the best practice out there, what's going on with other hospitals, and how can we evolve to ensure that we're staying current on evidence-based practice and our nurses are providing the best care possible. So just like we talked about in one of the other lectures about change, when it comes to evidence-based practice, you need to be a change agent, meaning that when there is new evidence that supports a change, we need to be ensuring that we're changing to stay current with what is the best outcome, what will give the patient the best quality outcome by the time they're discharged or even going home, so that their probability or chance of improving quicker is better. Now when we look at cost improvement, we also know that evidence-based practice does decrease costs. And it decreases costs by less expensive alternatives, appropriate discharge instructions, and they are always evolving with evidence-based practice. We need to ensure that we're delegating appropriate tasks, we're identifying and reducing complications with evidence-based practice, and we're also preventing hospital-acquired conditions by using evidence-based practice. This list could go on and on and on, but one of the big things when we think about discharge instructions and readmissions is that many hospital signs, the hospital reimbursement now has certain diagnoses for which if a patient is readmitted within a certain amount of time, that hospital diagnosis may not be covered. An example is congestive heart failure. If a patient is admitted with congestive heart failure, is treated for 4 days, and is discharged, and if the nurse doesn't do appropriate discharge instructions, or if the patient just chooses not to follow the discharge instructions, and the patient is admitted within 30 days, the hospital may not be compensated for that care. So evidence-based practice really does promote the nurse spending the time with the patient to do discharge instructions and making sure that they're communicating effectively to help decrease readmission rates, which we know also will help improve quality, because when patients are admitted to the hospital, their chance of actually getting worse can in some points be higher. I also look at the last bullet and I have to chuckle a little bit, because we prevent hospital-acquired conditions. You know, not only falls but infections. I think about years back, back in about 1998 when I became a nurse, we never put yellow gowns on. I mean, if I put a yellow gown on like once every 2 weeks to go in by a patient, we were lucky. You know, I don't know if we just didn't screen for them or we didn't know about them, or maybe some of them weren't, some of the microorganisms weren't around as prevalently as now, but I often think back and I think, boy, how much MRSA and how much C. diff were we really exposed to back then as compared to now, and how we have improved how we approach patients and how we've helped decrease hospital-acquired infections because of the evidence that was presented to us and the changes that we created to ensure patient safety. Okay, so when we look at quality improvement, we know that consumers demand quality-focused healthcare, and that healthcare facilities really encourage consumers to ask what how, and why we do what we do. Services really should be customer focused to provide patient satisfaction. And what we really want out of this, we want them to know what, why, and how, because we want to encourage and foster a trusting relationship that is improving quality and also forming that long-term relationship for which the providers know the patient and know what's in the patient's best interest. We also know that errors and near misses are investigated with quality assurance to determine what need to be changed, and through incident reports, processes and protocols are improved to create a better working environment. We also know that all healthcare facilities must abide by regulatory standards and requirements, and that the Medicare and state licensing authorities require different quality processes. One of these is Joint Commission, and this was the first regulatory agency. They address levels of performance in key areas. There is a large Joint Commission manual that all hospitals do receive, and it is through this manual that patients' rights, treatments, infection control, building standards, building codes, they are all, the organization needs to be compliant in all of the areas that Joint Commission has identified in order to get their endorsement for a Joint Commission hospital, and in order to receive the compensation around Joint Commission status. So Joint Commission is always looking at what is in the best interest of the patient and what is the best quality that can be put out. So when an organization has Joint Commission coming in, it is a very important event, because if they do not become Joint Commission accredited, it can have significant impact on the funding that they receive. So please know that Joint Commission is very largely involved in quality improvement, and there are many, many standards that the hospital organization has to meet before Joint Commission can say, yes, you are Joint Commission accredited. When I was working as a director of nursing, I went through a Joint Commission accreditation process with the clinics. And if you look up Joint Commission, you can even look at some of the standards, but there are many, many standards, and there are criteria within each standard that need to be, that the organization really needs to prove that they are competent in and that they are doing them. And it's not uncommon for a facility to potentially get cited on something, and then they need to create an action plan to improve whatever criteria they haven't shown full competence in. But it is a very stressful time for organizations, because somebody's coming in and looking at every aspect of the care that's provided, the environment that it's provided in, and how well are the nurses, CNAs, physicians, respiratory therapists, how are all of the entities prepared, and how are they providing quality care and promoting safety within the organization. We also know that there are clinical indicators, and clinical indicators are measurable items that reflect the quality of care, and they are used to monitor and evaluate processes and goals for quality improvement. We know that what clinical indicators do is they show how care is or is not carried out as it should be, and the focus is on clinical actions or outcomes of a clinical care area. So when I think of clinical indicators, there are many different clinical indicators, and it's just dependent on what the patient is admitted for or the hospital is monitoring. And within the cardiac realm, there are many clinical indicators regarding congestive heart failure, regarding chest pain, MIs, that providers have to ensure that they're meeting, and it is through these clinical indicators that they are tracked and they are compared to other facilities to making sure, you know, patients are on ACE inhibitors, patients get an echocardiogram. So there are different medical outcomes that are monitored in regards to clinical indicators to ensure that the quality of care is where it should be for that specific medical condition. And they can be compared with other hospitals. So we know that there are some process improvement tools. Process improvement tools support the quantitative and understanding of key work processes. These all have common steps. So the common steps include analyzing and clearly understanding the process, selecting key aspects of the process to improve, establish a trial or a target to guide improvement measures, collect and plot data, interpret the results, and implement improvement action and evaluate the effectiveness. So when an organization identifies an area of improvement, these are the 6 common steps that an organization or a unit, or even potentially if you want to do your own small process improvement within a unit, these are the 6 common steps that an organization, a unit, does need to work through to ensure that the quality outcome is put together in such a way that it will be accurate and ensure the steps are being followed to have a good maybe not a good outcome, but to be able to at least evaluate the effectiveness of the outcome. So when starting to create a process improvement project, an organization may use different flow charts. This is one of them, and this really maps out what actually occurs during the process. So it will it's like a top-down flow sheet. So it lists the main steps and sub-steps of a process in a linear fashion. And then we can have the deployment flow chart as well, which maps out the steps of a process and designates people or departments who will actually carry out each step. So this is just kind of a breakdown of how a project or how a process improvement can occur. Another chart is the Pareto chart, and this is a bar graph that selects key aspects to follow. So it's the key aspects within the process to focus on. So the height of the bars reflects the frequency that events occur or the effect events such as a process problem. So by focusing on just a few causes, a broader effect can be achieved. Then we have the cause and effect diagram. So this is a diagram that lists potential causes, arranges them by categories to show their potential effect on the problem. It's sometimes referred to as a fishbone diagram because it resembles a fish skeleton when completed. Cause and effect diagrams are also useful when localizing a major problem by using the Pareto chart. So like I said, oftentimes the Pareto chart can be used in conjunction with the cause and effect. First, we may track, I think on this the Pareto chart, it was tracking falls. And so it's kind of plotting, was it because, well, obviously it's not falls, but the Pareto chart can track and be able to identify maybe the lighting was poor and it's high. Now we're going to use the cause and effect diagram to break that down and to try to figure out why something is actually occurring so that we can fix it. And then we have run charts, and run charts measure data over time to evaluate patterns in process variation. They're sometimes called time plots, but valuable information can be obtained by studying trends, and it's from these trends then that decisions can be made or process improvement plans can be created. All right, so let's move into clinical care processes. So standardized processes, when effectively managed, are really the foundation for improvement in clinical care settings. Clinical pathways define the optimal sequencing and timing of interventions by healthcare providers for a particular diagnosis or procedure, and they are typically developed through a collaborative effort by the interdisciplinary team. Benefits can be a reduction in the variation of care, facilitation or expected outcome reduction in care delays and length of stay, improvement in cost effectiveness while increasing patient safety. We also have clinical algorithms, which is a decision path that a provider uses during a particular episode. So maybe an example could be a treatment of hypertension. We know that when a patient's blood pressure is too high, there are clinical algorithms that a provider can use to ensure that the hypertension is being controlled, maybe starting with diet and exercise. If that doesn't work, starting them on hydrochlorothiazide, checking their kidney functions, things like that. We also know that as nurses, there are clinical algorithms for providing basic life support, advanced cardiac life support, or maybe even some diagnostic screenings. We also know that for clinical care processes, care management is really being utilized much more in today's acute care facility, especially with highly ill or complex patients, because it matches the most appropriate services to the patient care needs, and it's in the most efficient and effective manner. So it's kind of putting that holistic look at the whole patient, having a nurse case manager look out over them to see, are we meeting all of the patient's needs rather than just A, B, or C, and not letting different areas fall through the cracks to help those complex patients through the medical system quicker without more complications. Now, when we think about safety, safety is obviously huge within quality. Patient safety and error prevention is at the highest most importance when caring for all patients. So safety initiatives focus on not only patient safety, but medication error, falls, preventing injury, not only for the patient, but also for the staff. And we know that a just culture promotes learning from adverse events, and it's recognized that all healthcare workers are human and can make mistakes, but shouldn't be held accountable for system errors. So when we have a just culture, we want individuals to be coming forward with safety concerns or errors that occurred, because it is through that the organization will learn how to improve the system to decrease the probability of further errors. We also know that healthcare errors result from human factors such as workplace circumstances, such as potentially nursing shortages, maybe provider training, so the lack thereof. If you're floating to another unit, there's a higher chance of an error if you're not 100% certain about the type of care that's being provided for that certain patient. And then provider interaction, so making sure that our nurse to physician or provider communication is at the highest that it can be to help decrease errors. I'm just going to show a quick video.
The following story was captured on video serendipitously at a meeting of 800 care providers. The speaker is a mother who lost her daughter at one of our leading U.S. hospitals, and this was only the second time that she had spoken to a public audience. We just happened to have a video crew on hand, and we were shooting a video of experts for a scholarship program when she began to speak. We just let the camera roll.
I began noticing that every time she saw a drink, she would scream for it, and I thought this was strange. I was told not to let her drink. While a nurse and I gave her a bath, she sucked furiously on a washcloth. As I put her to bed, I noticed that her eyes were rolling back in her head. Although I asked the nurse to call the doctor, she reassured me that oftentimes children did this and her vitals were fine. I told her Josie had never done this, and perhaps another nurse could look at her. After yet another reassurance from another nurse that everything was fine, I was told that it was okay for me to sleep at home. 2 days later, Jack, Relly, and Eva were brought to the hospital to kiss their beloved Josie goodbye. Josie was taken off of life support. She died in our arms on a snowy night and was considered to be one of the best hospitals in the world. Tony and I decided that we had to let the anger move us forward. We would do something good that would help prevent this from ever happening to a child again. It seemed the best place to start was with Johns Hopkins. Over the past year and a half, we have worked with the hospital to create the Josie King Patient Safety Program. Together, we launched the program last week. Josie's death was not the fault of one doctor or one nurse or one misplaced decimal point. It was the result of a total breakdown in the system. It was the result of a complete lack of communication between the different teams. It was the result of doctors and nurses not listening to a concerned parent. It was the result of a combination of many errors, all of which were avoidable. 98,000 people die every year because of medical errors. Hospital errors are among the top 4 leading causes of death in the country. This problem is unlike cancer, AIDS, or other diseases where we must wait for a scientific breakthrough in order to save lives. Hospitals are a man-made epidemic. Nurses and doctors make mistakes and lives are being lost. These human errors need a human solution. You are the only ones that can solve this problem.
The end of the Josie King story is yet to be written. The family settled out of court and took a portion of the funds, started the Josie King Patient Safety Program at Hopkins, and established the Josie King Foundation. We thought the story was so compelling that we donated the funds for production and distribution of the tape under 2 conditions. First, that we could give the videos away to hospitals if they make a donation to the Josie King Foundation. And second, that all such donations would be directly used to improve frontline care by the center. Since we produced the tape, administrators, physicians, nurses, and trustees have donated more than $250,000 to the Josie King Patient Safety Foundation. The video has been produced in a number of other languages as rapidly as possible to meet the need of international audiences. The work of the Josie King Patient Safety Foundation has been recognized by the Wall Street Journal and a number of other organizations. To make a donation to the Josie King Patient Safety Foundation or order additional tapes and DVDs, go to the Josie King Foundation website at www.josieking.org. Thank you for your donation and honoring Josie King.
So I think this is just a unfortunate example of many of the things that we talked about, the failure of communication and the failure for healthcare teams to work together. And I'm hoping that just by watching this short little clip, that it makes you realize how important these concepts are in order to provide safe, quality, effective care for our patients. If you're not clear about something, it's okay to call the provider or seek additional resources to make sure that your patients are getting the needs, their medical needs met safely. Okay, so the last area I want to speak to is just about informatics. And we know that informatics is manages information and improves communication across the system of care. And we know that informatics, thankfully, has really improved over the last, I would say about 10 years or so, if not more. When I first became a nurse, many things were paper, and now everything is really transitions to an electronic medical record, which is very great. that didn't sound good, but it's much better for patient safety. I often think about it would be the most effective if all facilities would be on the same platform of an electronic medical record. So if they were all going to use Epic, or if everybody was going to use Centricity, then information could be freely shared. However, we still do struggle in some contexts because not all healthcare organizations use the same platform, so it can be difficult. However, for those who do, it's much easier to track and be able to manage patient information. I often think about the Florida snowbirds, right? They come up here in the winter, so for 6 months of their 6 months of their life or the year, they live in Wisconsin, where the other 6 months they go down to Florida. and how is this medical information shared? And most of these people are sick, they have chronic illnesses, and I often think back to when I first became a nurse and everything was paper, and how, sure, things could get faxed, but sometimes it would take days. And if you had somebody in the emergency room and severe heart failure, what did the providers, where is the patient at with this? And now through the electronic medical record and the use of informatics, it really has ensured patient safety by being able to communicate more efficiently and effectively. Even if they are not on the same platform, it's still easier to be sent the information. Other things that have been implemented is obviously the rovers, the Pyxis machine. So there's many different types of technology that have been implemented and used within healthcare organizations to improve and manage patient safety and increase quality outcomes. Okay, so the last slide that we have is the implications for practice. So we know that standards of care are evidence-based, and that quality reporting is benchmarked against industry standards. Critical incidents are investigated within the just culture. Knowledgeable workers are rewarded. They are those who are engaged in their work, ask critical questions, and continually seek to improve outcomes of care. And so I strongly encourage you to be within this group. Seek out, engage in your work, ask the tough questions, ask why are we doing it like this. Do research even on your own to see what improvements could potentially be made even on your unit. It is through that inquiry and that quest to find a better way to treat our patients that's going to advance not only our nursing career but also the care that we provide for our patients. We also know that when this occurs, we have a healthier work environment, a healthier job satisfaction, and obviously you will want to stay at your job longer. If you know that you're making an impact within your profession, you will have a better satisfaction with your job and will want to go into work every single day and be excited to go into work. So that ends our lecture on quality. If you have any questions, please let me know.